So first of all, thank you to everyone attending and welcome to our May webinar of the Ecological Law and Governance Association. The theme of this month is Ecological Law, Policy, and Public Health, Climate Change, COVID, and a New Social Contract. And our host this month, we have a different organizational partner host each month, is the International Network for Epidemiology and Policy. And so everyone here today is actually part of INEP, and I'm the lucky person to also be a part of ELGA. So since the beginnings of my time with INEP, I thought, how can I bring these two organizations together? And today's the day, the first day of this relationship. This webinar is also supported by the Center for Environmental Ethics and Law, as well as the Ethics Specialist Group of the IUCN World Commission on Environmental Law. So I'll just give a little bit of a brief background about myself. I'll be chairing the session, and then the structure of the webinar. So the structure of the webinar will have 3 panelists, each at 20 minutes, and I'll go ahead and introduce each of them before they speak. Please try to keep everyone self-muted. It just helps with background noise. I have the capability to mute everyone, of course, but just try to self-mute. And then after each of our 3 panelists, we will have a question and answer time. And during that time, we will open the floor for questions. But if you think of any questions while the panelists are speaking, please don't hesitate to use the chat feature, and you can put it to the full group or directly to me. So a little bit about myself. I want to leave the majority of the substance to our great panelists today. But I am the Executive Director for the Center for Environmental Ethics and Law. And like I said, I also have the pleasure of sitting on the Executive Committee of the International Network for Epidemiology and Policy, as well as a founding member of the Ecological Law and Governance Association. That's all I'm going to say about myself. You guys can Google if you want anything else. But I want the attention on the topic of the day. Now, to give a little bit of background into INEP, the International Network for Epidemiology and Policy, it is a 501c3 nonprofit based in the United States, but it is international in scope, purpose, nature. In fact, we're the only global network of epidemiologists and public health experts that brings together academics and practitioners, so the public health officials, to bridge this nexus between our necessary research and public policy development. Right now, we have 24 member society organizations from around the world, and each of these epidemiology or public health organizations is a society in itself. So, for example, we have the German Epi Society, we have the Japanese Epidemiological Association, the Australasian Epidemiology Association as well, which Ying may tell us a little bit more about, the International Society for Environmental Epidemiology, et cetera, et cetera. And then we also have expert advisors for particular working groups and the projects that we do. And that's where Bruce Jennings comes in, and he is an expert advisor with our ethics working group. So the mission of INEP is to promote integrity, equity, and evidence in policies impacting health. We do this by working with government and non-government organizations, including scientific journals and the media. We do this to protect the whole community of life. Our goal is to provide an international forum to discuss any policy concerns related to epidemiology, and then create and disseminate diverse forms of evidence-based knowledge. So to date, we've had work in gender equity, climate change. It was one of the recommended readings for today. Lead, asbestos, e-cigarettes is one that we're working on now, finishing up. Conflict of interest and disclosure, which also highlights another important area of our work, is that we work to recognize and highlight the misuse and corruption within the science and profession of epidemiology. Now, of course, it's all clear to us the link between public health, equity, integrity, and function, and ecosystem health, integrity, and function. But our duty, of course, is to make it clear to the decision makers. How do we do that? Now, ELGA was created as a direct response to the failure of environmental law to protect the environment. It's a sectoral, piecemeal, anthropocentric, low priority approach to this systems-based, whole earth-based, interrelated, interdependent ecological law and governance. And so of course we need the voice of epidemiologists, of course we need the voice of public health experts. Even now with COVID, like climate change, has made abundantly clear the vast system inequities and connections. And it has also shown us the need and ability, at least in some nations, to respond quickly to urgent threats, which we need more of in climate change policy. And on that note, I would like to turn to our first speaker, to Wael Al-Dalami. He is an epidemiologist and professor of global health at the Department of Family Medicine and Public Health, University of California, San Diego. He is co-founder and associate director of the UCSD Institute for Public Health. His research has focused on chronic diseases among children and adults and worked on studies of respiratory illnesses, cardiovascular diseases, diabetes, and cancer. He helped introduce climate change and health as a new area to UCSD and the School of Medicine, and was selected by the Chancellor to represent health sciences on a campus-wide committee on understanding and protecting the planet. He led the formation of the Working Group on Climate, Environment, and Health as part of the Institute of Public Health. This made climate change one of 3 focus areas of the Institute, which led it to be a focus area for the entire UCSD School of Public Health. He was the chair of INEP from 2015 to 2017, where he led a consensus paper policy brief on climate and health, representing the views of all member organizations, and that was part of the recommended readings as well. Prior to joining UCSD, he was a fellow at Harvard University and a scientist with the WHO, International Agency for Research on Cancer. He has published more than 100 peer-reviewed publications, and his recent work involves developing evidence-based policies and research ethics. His most recent publication, which I'm very excited about, Health of People, Health of Planet, and Our Responsibility, Climate Change, Air Pollution, and Health, is now available on open access, and it's also linked on our page. And it's had 15,000 downloads in just a few days, so congratulations, Wael. Lastly, he is section editor of Global Health and Sustainability in Springer's journal, Current Environmental Health Reports. And Wael will be speaking on climate health impacts and a way forward.
Thank you, Katie. And I want to say that today I checked and it's 17,000 downloads. So it seems it's interesting. There's interest in it. That's great. So I'm going to go a little bit quickly, just kind of an overview, given the vast topic that I'm trying to cover, but I want to give a little bit of everything. And then maybe also leave with some solutions. Is the PowerPoint shared, Katie? Good. So what we knew in terms of climate change has been there for a while. Actually, even in the 70s or before that, global warming is related to greenhouse effect. And the aspect that really began raise alarm is the temperature records that appeared to be warming in 1980 to 2000. So this is the figure that really shows this, and in it we see that the from 1880 to 2000, there's an exponential increase in the annual temperatures. And that is where it was becoming clear that was like from 1980, they predicted if it's going to increase that much, then we are in serious trouble. And that's really what happened. By 2000, it was clear we are in a new era and a major problem. Now, I want to kind of touch base that climate is not the only problem. Climate is part of the whole Anthropocene, which includes aspects related to the planetary health and aspects of water, energy, agriculture, ecology, but also poverty and overpopulation are all factors contributing to this Anthropocene, where is the era of man-made impact on the health system of the earth. And this very nice paper by Stefan et al. In 2015 really gives a very amazing picture of why this is happening. And all these figures of use became exponential. You can see from the previous years it was just gradual increase, but then it became exponentially increasing, and it's still in this upward, whether it's energy use, population, the GDP, the income, transportation and population, water use, but also with it is disparity, huge disparity. So many people exist only on 3 gallons of water per day or less. And while that is almost the amount that could be used for flushing 1 flush of toilet. And these are pictures of, abuse of water. This is just a swimming pool, this big thing. And then, places like golf fields that consume so much water to cater for those who are wealthy. Again, marine fish capture, forest loss, and we all see these pictures of the consumption of energy and also the impact on the ecology and environment, as well as waste. All these are factors. 40% of what is produced is wasted. That's a lot of impact on climate as well as the health. Again, unsustainable agriculture, and all these aspects have been linked one way or the other to increasing the impacts of climate change. Now, climate change, we know, caused these conditions or situations: flooding, environmental refugees, food insecurity, infectious agents, heat, extreme weather, water quality issues, increased allergens and pollens, and economic impacts. Now, until recently, and I say recently, maybe 10 or more years, maybe maximum 20 years, there wasn't that emphasis that climate change could have an impact on health as much as it was focused on the ecology and environment. However, all these factors, as you can see, are actually impacted and related to health. So in essence, climate change is a very important contributor to the health of the population, and it is going to be for the coming century. So this just kind of direct impact that we know is the heat waves, and there has been an increase in heat waves all around the world, and there will be more increasing. So there has been about 2,300% increase in death from heat wave in the last century because of 1 Celsius increase. So if the business as usual model goes that we are going to increase to 2 or 3 Celsius, you can see what kind of death and damage could that happen, could cause. Those who are having heart problem, asthma, and elderly are very young, and the homeless are the most vulnerable, especially labor workers and those in low-income countries. Despite that, the disparity is there in terms of all these aspects. Actually, we are now seeing that no one is immune from the impacts of climate change, just like we're seeing with the COVID-19. So in this 2003 heat wave in Europe, the heat didn't increase so much. It was few Celsius degrees, but the people were not prepared, and especially in France. I happened to be in France actually in that summer. I recall it very well. And I was in a high-rise building, but there is no AC, no air conditioning. So when you open the window, it's hot air coming in. The people were not prepared, and a lot of people died, especially those who are old, those who are living alone, and they gradually deteriorated without realizing, and they found, or many were found dead in their apartments, or made it to the emergency room but died. So as a result, 70,000 deaths were attributed to that heat wave in all of Europe. Mostly was in France. And a few years after, this was 2003, in 2010, there was 54,000 deaths attributed to heat wave in Russia. And afterwards, in 2015, 65,000. These are huge numbers, but they are, they are subtle. People are not appreciative of it as like the COVID-19. So this is going to be even worse. As a matter of fact, in the Middle East and North Africa, it will become so hot that human habitability will be compromised, that it will no longer be possible to live in these countries. For example, my native Iraq, 160 days per year will be above the 90th percentile temperatures. And that's almost half of the year. In Kuwait, similar. In Beirut and Riyadh, almost 200 days per year are going to be so hot that reaching 60 Celsius, and it would be not possible to be outside. The future look is that about 3.5 billion people will be exposed every 2 years to mean summer temperatures that are above the hottest summers ever recorded. If global warming increases by only 0.5 Celsius, which is, the minimum that could increase, it is expected that it's going to be more. There will be an estimated additional increase of about 1,200% deaths from heat waves as well. So the heat waves also are related to increase in infections. And this is also another impact, become almost indirect effect, because the hotter, more humid weather means more mosquitoes, breeding cycles. They go into new areas that previously did not exist. Dengue virus is also spreading and very well linked to temperature. And the Lyme disease, Rocky Mountain spotted fever, and so on and so forth. All these are well evidenced that are increasing as a result of the global warming. There are other aspects of food poisoning and waterborne diseases, and so on and so forth, all interconnected. Wildfires, which people might not have linked previously to climate change, are becoming more and more intense. In California, there has been a 1,000% increase in intensity. That was because of warming of the planet. And the Camp Fire, the most severe in the recent history in California, in 2 weeks, there were 88 people killed. 90% of the city was destroyed. 19,000 buildings were destroyed, and the cost of $16.5 billion. That is in just 2 weeks, this kind of loss. And this picture oversees all these were houses became flat. It was like a war zone. So these are going to be increasing more and more and more. We also all heard about last year, the fires in Australia and the Amazon, unlike anything before. So unfortunately, this is going to be the new norm, that we are going to have this every year and spreading in all around the world. So relatedly, droughts is another problem. Drought is becoming common. We had in California a spell of about 7 years of a drought. We were rationing water so severely that now everybody basically is changed all their landscape and everything to something that doesn't require water. And this has also an impact on the well-being of laborers, farm workers, those who are dependent on rain and water. And that has been also related to suicide. Actually, in Australia, in severe droughts, there's been an increase in suicide of farmers after their loss. Also related to drought is when the crust of the earth becomes dry. then it has more likely to transmit fungal diseases as well as the valley fever, which is a rare disease but can cause damage and lung damage and death. And it's been shown can travel up to 75 miles because of drought. The other aspect is water quality, and by 2070, more than 130 coastal cities with 1 million or more inhabitants will be affected by flooding, and that will affect 150 million people. In the US alone, 50% of the population live in low-lying coastlines. And this is a picture from San Diego near the border with Mexico. And this is an estuary that goes actually from south to north. So it comes from canyons from Mexico, from Tijuana, and then feeds into the beaches and lower south of San Diego. And you might see here there's a plume. This is after every heavy rain. All this comes from these canyons into the water system. And of course, beaches are closed, but these bring with it a lot of chemicals, a lot of toxicants that come from the places where our dump sites actually into the water. So all these are going to be affecting coastal areas, but not that, even beyond that. This is a study that was done by one of our colleagues here in San Diego. They went and sampled the level of toxicants in fish all around the world and in the different seas, and they found all of them, tuna fish specifically is what they studied, have all these different levels of toxicants, and these are going to end up in our system. So all these are interconnected: the drought, the rain, the sea, and the oceans, and the food chain. Then we have air pollution. That is a major cause of death. So it has been linked to many health problems. It causes 28 years lost from life from those who die from air pollution, 28 years earlier death. 7 million deaths per year are attributed to indoor and outdoor pollution, and 30% of stroke have been related to air pollution, as well as the wildfires increases these pollutants. Flooding, again, this is becoming much more frequent, increased by 300%. The hurricanes by 25%. There is more flooding, and 1 billion people were affected by flooding. This is causing more injuries and death, increased risk of infectious disease, as well as health problems. This is a picture of sewage outbreak in one of the cities in the Carolinas after the flooding. So this is going to be transmitting all kinds of diseases to every home in that area. So all these are disrupting the health services and requires medical surge, causes long-term impacts, and there's disparity, and we are still not prepared. This is a picture from South Carolina, and showing that with sea level rise at 4 stages, at 4 feet, so at each feet, there are more and more health systems impacted. So you can imagine if the health system impacted and the people are impacted, where are they going to go? It's going to be a double burden of this condition. I want to kind of summarize also something that is related to the environmental risk and immigration. About 600,000 people perished and 4 billion were displaced as a result of extreme weather. And this has also been related to conflict. For example, in Syria, they have attributed some of the factors related to climate change to the uprising, although it is really a risk multiplier and it wasn't the direct cause of that conflict. But this relationship of conflict leading also to open illegal immigration and exaggerating the climate refugee situation. And then we have also conditions such as increasing slavery, violence, and death. Like in Libya, because of all the political instability, a lot of people are using that as a route to go immigrate, and there is 10 times more high risk of drowning, and 1,000 in one summer, 1,000 drowned. So these are some of the pictures of refugees and the status that we are familiar with, the sad situation. And this is a picture of where the migration is coming. So it's coming from people who are not just in conflict, but also who are in economical deprivation, in drought, and so on. So it's exacerbate. There's poverty, there is limited energy, water, and climate change. There is political trigger and wars, and we have refugee crisis. What are the challenges? The challenges of climate change health is that it is indirect. Most of these conditions are not directly, so people cannot make this connection easily, except maybe heat waves. But all these conditions are an indirect impact. There's also the political problem. There are climate deniers, and those are people who are really doing this as a profession. Many of them work for the tobacco industry, and now they're working against climate. One Senate member receiving over $2 million from the fossil fuel industry, and his aide, also staffer, became funded by the Exxon and Chevron and are very well-known climate deniers. There are institutes named in environment and energy, but they are actually funded by the fossil fuel, and so on and so forth. All these names, and also the media, 86% of climate news on Fox News is denial. So these are all challenges. Also in the US, we have a problem with the political affiliation because Al Gore is a Democrat. He started in 1989 talking about this. So now all the Republicans say it's a democratic thing, and they're not gonna listen. Not all, but I would say a majority who have this view of denial might be related to political affiliation. There are also upstream ethical predictors that energy crisis and plundering of the resources, the culture of consumerism, overconsumption and wasting, and indifference to these impacts. So I want to end with the golden rule of ethics of reciprocity, that one should treat others as one would like others to treat oneself. And these are in all the main faiths that we know in Christianity and Islam and Buddhism and Judaism. It's all supporting this golden rule. And so that's one of the solutions we are envisioning as a way to address climate change. Faith leaders have all came out against climate change, beginning with the Pope Francis, the Church of England, the Dalai Lama, rabbinic letter, and also Muslim scholars. And those, form more than 50% of the population. So they are going to have an impact. And that's really where our book came in, which is just published, as I mentioned, 3 days ago. And it was an invitation by the Vatican to bring all these scholars from all over the world and talk about the health impacts. And we published the book based on that. And it was held in 2017. And it has 33 chapters, including faith leaders, political leaders, health scientists, social scientists, and physical scientists. So I know probably I'm over time. One of the other things we really need to talk about is behavioral change and how we can be less reliant on energy that is fossil fuel energy. But the policy is really now the key we have. So this is our INEP, and thanks to really Katie's hard work and even this website that she helped design and put together, INEP is one of the organizations that is helping in that aspect in terms of addressing policy. So we published a climate change and epidemiology policy brief, and basically saying that the health aspects of climate change are complex, require interdisciplinary research. Policymakers need to work with epidemiologists, and there is a need for funding agencies to support that, as well as new methodological approaches. So humans and their healthcare and their health are the ultimate beneficiaries from protection of the planet. There's a major deficiency in assessment of health impact of degradation of the planet and its environment, and interdisciplinary science will move forward the innovation appropriate for future of the planet, as well as the Anthropocene and climate change, is really an ethical and moral argument. That's how we should say that, and that's how we should advocate for it. And I want to end here.
Great, thank you so much, Wael. An excellent beginning to this conversation we're having today. And I see some questions have started to come in as well, and we'll save those for the end. So for our next speaker, she is Ying Zhang, and she is an associate professor with the Faculty of Medicine and Health at the University of Sydney. She is a senior epidemiologist with over 15 years experience in conducting research on climate and health. Ying's research aims to build community resilience to changing climate and environment, with a focus on the most vulnerable populations in the Asia-Pacific region. Ying currently co-chairs the MJA-Lancet Countdown on Health and Climate in Australia. She is a board member of the Australian Climate and Health Alliance, treasurer of the Australasian Epidemiological Association, and the Capacity Building and Education Committee member of the International Society for Environmental Epidemiology. And Ying will be speaking today on tracking progress on health and climate change research to support decision-making. Thank you.
Thank you, Katie, for the introduction, and thank you everyone for joining the webinar. It's a really pleasure to be here to talking about our specific project to track climate change and health research. And I will briefly touch on both the global and Australian perspectives. And thanks, Will, to give the big framework and big picture as a perfect background to my talk. I will share my screen. Oh, okay, I have to play it. Oops, sorry. Is it looking okay?
Oh, that's perfect.
Okay, great. As Katie mentioned, that I'm fortunate to co-chair the MJA-Lancet Countdown, Medical Journal of Australia, and Lancet Countdown on health and climate change for Australia. Since the 2017, we established a team to follow the global efforts to track the progress on health and climate change. And as you have heard from Will, that climate change is significantly impacting our health globally. I will start with acknowledgement so that you know who we are. And our multidisciplinary team is made up of 20 experts from 12 institutes across the country. So on behalf of the team, I would like to thank the national team and also the global countdown team and Medical Journal of Australia, who officially published the national report, and the leadership at University of Sydney. And I co-chair this project with Professor Paul Baggs at Macquarie University. And Royal Australasian College of Physicians, IACP, and Australian Medical Students Association have formally endorsed the policy briefs that we developed based on our findings for policymakers in Australia. So these are the two key projects that I will briefly touch on today. And the Lancet Countdown, for those who don't know this project yet, it's the global effort to track health and climate change at the global level. And LancetCountdown.org website has all the documents, and even this year they released the data sets they have used for their analysis. And in Australia, we established a team a couple of years ago following the global initiative. And we published the first report in 2018 and the most recent report in 2019. And if I have provided the readings, so if you need to know more details, feel free to look at the papers that they're published online and freely available to everyone. And just start with the global perspective. About 10 years ago, climate change was formally recognized as the biggest global health threat in a paper published in Lancet in 2009. Since then, there are a few global initiatives developed to address climate change and health issues. And one of them was the Lancet Countdown Project, which builds on the success of the 2015 Lancet Commission on Health and Climate Change to track the global changes on climate and health research. The Lancet Countdown reports not only climate change risks and impacts, but also the opportunities, highlight the opportunities that tackling climate change could be the greatest global health opportunities of this century. So the first report of the Lancet Countdown was published in 2017 and will be updated each year until 2030. In addition, along the main report, which is about 40 pages long, there are additional policy briefs for at least 10 countries, including the big carbon polluters in the world. So these are the aims of the Global Countdown Project: to track the impacts of climate change and the speed of the transition to decarbonize the global economy, analyze the health benefits available from climate change mitigation adaptation, and also provide a global picture of success stories in the shift to a more environment friendly global, and also showcase the studies for shared learning, and more importantly, to engage with policymakers and broader health community to better communicate and contribute to policy advocacy. So I'd like to show you a small video that perfectly summarizes what they have found so far and lay the foundation for our national project. So I apologize, I haven't seen this before, but it's quite nicely addressed the project.
At every stage of their lives. The Lancet Countdown, tracking progress on health and climate change, monitors our choices, demonstrating what action, or the failure to act, means for human health. There are many paths we can take. An uncertainty, where a child has to fight simply to survive, to an environment that creates the conditions that allows them to thrive. If we continued on our current path, a child born today will live through a world that is over 4 degrees warmer, with a changing environment threatening the foods they eat, the air they breathe, and the communities they grow up in. Air pollution, already dangerously high in more than 90% of cities, will worsen and further damage their hearts and lungs from the moment they take their first breath. As they grow, food insecurity will rise, with children among the worst affected by the malnutrition and stunting that comes from crop failure in a more volatile climate. Throughout their adult lives, they will experience more heat waves, stronger storms, the spread of infectious disease, and see climate change intensify mass migration, extreme poverty, and mental illness. But the future doesn't have to look this way. A global response that limits temperature rise to well below 2 degrees will transform the life of a child born today for the better. Children in the UK will see an end to coal by their 6th birthday, and the growth of solar and wind energy, resulting in cleaner air across the country. In France, the last petrol car will be sold by the time they turn 21, with cycleways and green spaces supporting safer and more livable cities. And they will celebrate their 31st birthday as the world finally reaches net zero emissions, securing a healthier future for coming generations. Which of these two pathways the world travels down will depend on the decisions of individuals, businesses, and governments. And only an ambitious response can ensure that the health of a child born today isn't defined by a changing climate. Visit the Lancet Countdown online to find the latest assessment of the state of health and climate change in your country.
Okay, I'll go back to the slide. Katie, was the screen showing properly? Yeah, good, thanks. As you can see that from the short video that some of the key messages have already been highlighted in Will's previous talk, and just also highlight which way we are going down the track really depends on our efforts from the whole society. And can you now see my slides again? Yeah, good, thanks. Now I will move on to the national countdown in Australia. In Australia, we published the first national paper in 2018. Why we need a national report? There are many reasons, as you would understand. Australia is one of the top countries with high carbon emissions per capita, and also a major exporter of fossil fuel to other countries. So what is happening in Australia, and Australia's policies very important to the health of other countries as well. And there is a need to understand what have been achieved so far in addressing climate change and health at a national level. But the data sets from the global report is not comprehensive for us to understand this. So we aim to track the health impacts of climate change and the transition to a decarbonized society in Australia, and provide a national picture of achievements and the challenges in the shift to inform policy making, and more importantly, to engage with broader communities as well. And luckily, Australia has the capacity to develop its own countdown report, which is ahead of the other countries. At the moment, we are the only country that has published the national level countdown report, and we also aim to update the report annually until 2030. And the framework largely followed the global report methodology, but with adjustments based on Australian data sets and the contexts. Why it's not moving? Okay, it took us more than a year to complete the first report, which has more than 9,000 words in the main text and additional 9,000 words in the appendix with more details and methodology. As you can see here, we have 41 indicators in 5 major sections, covering health impacts from extreme heat, climate-sensitive infectious diseases, food security, and changes in labor capacity. And national and city-level adaptation plans for health preparedness for health emergencies. And also carbon intensity of the energy system, zero carbon emission electricity, and so on. And section 4 is about economic loss due to climate extreme weather events and investment in new coal fossil fuel industries. And the last but not least, the section on engagement, we analyzed media coverage, scientific publications, and documents from government and corporate sectors on topics about climate and health research. Why it's difficult? Okay, last year we updated the report, but with fewer indicators across the same 5 sections. The main reasons is that some of the indicators didn't have sufficient data to make meaningful analysis last year. But we added several new indicators, for example, the bushfire exposure in Australia, which is very relevant and important to Australian context. And we also added a few text boxes to illustrate important issues, but we don't have sufficient data to develop them into indicators. For example, the inclusion, integration of health and climate change content into the medical and health curricula. So because of time limit, I'll only show you 1 or 2 indicators from each section to give you examples of what we have analyzed in the report. The health consequences of extreme heat are significant, given we are having a much warmer globe. The intensity of hazard posed to health by heat waves, as measured by the excess heat factor, has more than doubled in the past 20 years. In Australia, each state has already developed a heat health action plan, but we need advanced national coordination among different sectors, and especially pay more attention to the need of the most vulnerable populations, which was mentioned by the previous talk as well. The indicator for bushfire is very new, and we call it wildfire as it is in the global countdown. But bushfire we use in Australian context. We have found that Australia have experienced increased exposure between the 4-year comparison periods. You know that the increase is not that significant or big jump, but that just because that we didn't capture the major bushfire between the 2007 2009 because of the analysis. But this year we will improve this indicator and mainly track what the lessons learned from the unprecedented bushfire in Australia earlier this year. I have trouble in clicking the slide. What's happened here? Okay, section 2 on adaptation, we have found very little changes in Australia's adaptation space, unfortunately. We still don't have a national strategy to address climate change and health, even though there is a proposed framework developed by the Climate and Health Alliance in consultation with health professionals. At state level, there are some progress have been made, but Tasmania has been the only state having the most comprehensive strategy to address health and climate change. This is frustrating. Section 3 is about mitigation. New data have become available up to 2016, but we found little changes since last report. Australia is far below the other comparable developed countries such as the UK and Germany. Australia's energy system remains highly carbon intensive, highest of developed countries. Is on the top of this picture, as you can see here. But on this slide, in contrast, Australia is down the bottom of the picture in terms of generating renewable energy. So from 1990 to 2016, the share of electricity generation from renewable resources increased from 11% to 18%. However, Australia continues to have a much smaller proportion of electricity from low carbon sources compared with leading countries. And we need to accelerate the transition to renewables. And in section 4, about finance, we checked the changes in employment in renewable and fossil fuel energy industries. This indicator suggests that employment in renewable energy activities has increased by almost 30%, following a 25% increase over the previous financial years. And note that over the same period, the employment in mining operations also increased by 7%. Just being naughty. And last section about engagement on health and climate change topics, we reviewed the newspapers and scientific publications as well as policy documents. Unfortunately, there has been no engagement in the topic on the topic as at the federal government level over the past 10 years. We see some progress in state and local governments, but that's a big concern for Australia to make collective efforts to move forward. In conclusion, we find mixed progress on health and climate change in Australia from our last report. One important feature of the last year is we had the federal election. Unfortunately, the result is not in favor of the climate change research community. We are facing increased exposure to heat and bushfires and other extreme weather events, but little progress in adaptation and mitigation. And overall, we lag behind other comparable developed countries. And the lack of engagement by the Australian federal government is of significant concern. And based on the findings, we conclude that Australia remains at a significant risk of declines in health due to climate change, and that substantial and sustained national action is urgently required in order to protect people's health. So we also developed policy brief for Australian policymakers, and these are the 3 key recommendations focusing on adaptation, mitigation, and risk reduction for vulnerable populations. And this year, all the countries signed Paris Agreement are required to update their national NDCs, nationally determined contributions, which are the country targets of reductions in greenhouse gas emissions under the UFCCC. Australia should integrate health considerations throughout the proposed interventions for both mitigation and adaptation, with particular consideration to policies concerning energy, heat, and health systems. And these are the overall recommendations from our report. And I've also listed the key recommendation from the previous year's report. And you can see the key recommendations are slightly different, but overall aligned with the goals that we would like to achieve to act on climate change and health issues. So the questions or the implications for you to think about is, can you develop some indicators to track progress and assist decision-making at different levels in your area? What can we improve in working with local communities to meet their real needs through better engagement with stakeholders? And how can we do better in advocating policymakers and mobilizing all societies, including health professionals, to act on climate change? I think that I will finish here. And we are in the process of developing this year's report. Sorry, I can't release much information at this stage, but it will basically focus on the lessons learned from the bushfire and also cover multidisciplinary perspectives. And keep an eye on the progress and watch this space. And please feel free to contact me if you have any questions. Thank you.
Thank you so much, Ying. And I think it's of particular importance that both you and Wael have now mentioned the particular political power of climate change action or inaction. You know, you take us down these worlds of yours of data and numbers and science, and it still doesn't quite move the needle if you have a hostile or inactive government. So it's definitely things we need to address, and also why we need one another to address these things. So now we'll move on to our final panelist, Bruce Jennings. He will be speaking on Beyond the COVID Crisis, a new social contract with public health. He is an adjunct associate professor of health policy at Vanderbilt University Medical School. He is also senior fellow at the Center for Humans and Nature and senior advisor at the Hastings Center, where he served from 1991 through 99 as executive director. He served as editor-in-chief of the Encyclopedia of Bioethics, entitled Bioethics 4th Edition, a 6-volume collection published by Macmillan that is the standard reference work for the interdisciplinary field of bioethics. Mr. Jennings has been active in the health policy and end-of-life care arenas and in public health and environmental policy. And he has also been active in the development of in the field of public health ethics and taught one of its first courses on that subject in the country at Yale School of Public Health from 95 to 2014. From 03 to 09, he served as a member and chair of the Ethics Advisory Committee of the CDC. From 2017 to 2019, he was chair of the American Public Health Association's task force charged with writing a new code of ethics for public health, which was just adopted in October 2019. He's also worked in local government and community service, even as an elected village trustee in Hastings-on-Hudson, New York. So he knows what it means to carry our words into actual policy. In that position, he spearheaded the village government sustainability effort, including enacting a green building code, one of the first such laws at the local level in New York State. A political scientist by training out of Yale and Princeton, Mr. Jennings has written and edited 29 books and has published numerous articles on bioethics and public policy. Welcome, Bruce.
Thank you very much, Katie, and thank you all for joining us this important discussion and conversation this afternoon. I am going to address perhaps a very specific kind of activity and aspect of this very broad problem that has been so well described by our previous two speakers. I'm going to be talking about disaster or emergency preparedness planning as an activity and how it might be done and how it might be understood conceptually, and what some of the practical, political, and social benefits and outcomes of it might be if it were done somewhat differently than it has been practiced, at least in the United States, in the past few decades. So I have a very specific focus, but I hope to tie it in with the broader problems. And the starting point for my own thinking about emergency preparedness and planning is that it's increasingly unrealistic in light of what we have just heard and what we've been seeing for several decades now globally. It's increasingly unrealistic to separate public health mitigation, emergency, adaptation kinds of activities from environmental, ecological, climate-related, Earth systems, safe operating margins related issues. Public health, human health, and ecological health are essentially now merged, it seems to me, and it's very problematic to drive a wedge between them and to see them as either-ors. As far as ethics is concerned, I think they are both, as I believe the previous speakers have emphasized, and I agree, both public health and ecological and environmental policy and practice sustainability are at bottom ethical enterprises. And ethical discourse is essential to building the political support and governance that's necessary to really have a strong response. So that's pretty much what I will be talking about in the next 15 minutes or so. Let me share my screen now. I have some slides to go along with my argument, my presentation. Let's see, where is it? There we go. Okay. All right.
Looks perfect.
Okay, good. So right now, the world is gripped with the COVID-19 pandemic. And certainly pandemic infectious disease emergencies are one extremely important aspect of public health and disaster emergency preparedness and planning. But they are only one, and it covers an all hazards approach, a very broad number of things and stressors that can disrupt or overwhelm the capacity of healthcare systems and civic public safety systems and infrastructural basic service systems in a community or even over a very broad scale, with many untoward stressors and emergency things, events and determinations. So we have a broad plate for emergency preparedness planning. Disasters, by definition, are times of extraordinary circumstance. The injury, suffering, and death they cause are tragic, but their social and civic significance is that disasters bring traits and behaviors to the surface that are ordinarily latent in everyday life. That is the ethical peril and the ethical promise of disasters. Strange thing to say, but I hope I'll make it clear what I mean. Widespread moral indifference and conflict may arise, but so may widespread responsibility and solidarity. To facilitate the promise and to stave off the peril of disaster situations and abnormal times are the ultimate aims of emergency preparedness as what I refer to as a civic function. Emergency preparedness is not just a one-time thing, and it's not just for what happens when a disaster occurs. It's an ongoing community and civic function that is part of what allows our societies to be resilient, to be democratic, and to be, as it were, environmentally and public health-wise, intelligent, just societies. Public health emergency preparedness is a capability of communities, health systems, and individuals. It is a capability to plan and prepare in advance, to respond during the immediate crisis, and to recover afterwards. So it is a preparedness in advance, a response in the situation, and a rebound and recovery phase, a kind of question that we're dealing with here. What might be said to be the ethical goals of public health emergency preparedness? This particular formulation that I'm sharing with you here grows out of a United States Centers for Disease Control and Prevention ethical guidance document on emergency preparedness and planning that I helped to prepare several years ago. And listed there are the goals of what we're trying to do. And you can see that the goals of emergency preparedness really touch on the general democratic and justice goals of an entire society all the time. And we need to take them into consideration. We need to think analytically and intelligently about how to handle possible conflicts or discrepancies between meeting all of these goals simultaneously. There can be situations in which some of the goals such as the first, may conflict with the second, that there may be a tension between individual freedom and liberty and public health goals of harm reduction and well-being health and well-being promotion. This is now being debated and discussed in many societies affected by COVID-19 in terms of the impact of social distancing, testing, and contact tracing and quarantine, classic public health responses to limit the spread of infectious disease. COVID-19 is a biologically unusually infectious and transmissible organism, and therefore the pressure to quarantine, isolate, and separate individuals and to forego activities, social and economic activities that bring people into close proximity to one another is a very real dilemma and tension in our society today. But nevertheless, we should take a broad view, I think, of the various values that are at stake. I want to focus in this presentation especially on the goal of trying to develop community strength and resilience. We want to develop strong, just, and democratic societies as well as safe ones. And a responsible civic response. Disaster planning activities should promote a sense of personal responsibility and citizenship. And those are interesting and not obviously health or environmental goals, but I think underlying the question of how do we achieve public health and well-being of our society, how do we achieve sustainability and right relationship between human activities and natural systems, what makes that possible? What makes that possible, in my opinion, or one of the things that makes it possible best over the long term, is for us to tend and make resilient and devote ourselves to diversity and democracy in our governance, in our societies. Authoritarian societies, closed societies, might be able to respond to a particular health or environmental emergency rapidly and effectively, but over time will not, I think, be the most appropriate and the most long-lasting and successful form of either health or ecological governance. We can debate that point if you want, but that's one of the premises of my argument today. In addition to the ethical goals, there are certain values that are at stake in the planning and implementation process itself. And properly done, disaster planning can be one aspect of a broader public sphere in a democratic society to contribute to a discourse and to a set of reciprocities and relationships among members of the society that have the following attributes. We can stress and reinforce reasonableness, transparency, inclusiveness, and accountability. And by tending to these values and not simply articulating them verbally, but trying to build the institutions and the circumstances, the forum opportunities for individuals to broadly participate in a structured, practical activity that is devoted to these kinds of values, will, I think, again, be one of the most effective ways that we can, as it were, I don't want to use this metaphor too loosely, we can immunize ourselves, perhaps, against the concerted disinformation campaigns of climate denial, of all kinds of blockages that have been deliberately, not sort of spontaneously bursting up from the grassroots of democratic societies at all, but have been, in fact, deliberately constructed to undermine some of the fundamental functional requirements of an effective democratic society. So I mentioned the longer term effects of the kinds of practices that I'm talking about. Now, I have referred to communities several times so far, and the idea of community is a complex one, of course. And there are at least three important ways that we can look at it. We can look at it as a set of individuals who try to influence each other. We might refer to that as an association. We can look at it as a structure of institutionalized patterns of behavior and norms. We might see that as a system, a social system. But it can also be looked at, and has been looked at traditionally in our political history and political traditions, looked at community as a space of deliberative civic agency in which individual agents acting together both reproduce and change the social, institutional, and cultural meaning and normative context of their activities and of each other's activities. A civitas, a civic society, a civic community, a civic practice is one way to see what we are trying to construct if it doesn't exist, sustain and reinforce if it's already an ongoing practice in our societies. So how should we think about community emergency disaster preparedness planning and response? It seems to me that there are two modes, two basic models, as it were, of thinking about disaster planning. I want to contrast them. I want to put labels on them a little bit. One of those modes I'll call the consumer model. The other I will call, obviously, from what I just said, the civic practice model or the civic model. It's clear to me that in the United States, at least, and I dare say in many other countries as well, the practice of emergency preparedness planning follows and is understood as along the lines of a consumer model. What I think that we need to do, if we possibly can in the years ahead, and maybe we can come out of the COVID-19 experience more open to and more attentive to the importance of shifting our models and our ways of thinking, our frameworks about preparedness and community planning and mitigation and adaptation planning, is that we move away from the assumptions of the consumer model and we move toward the assumptions of a civic model. Now, the consumer model sees emergency planning as rather like medical or financial planning. Providers with specialized knowledge are preparing a product for clients who are using a product to promote their own interests as individuals, as consumers. It's a self-interested, market-oriented mobilization of specialized knowledge and expertise to provide a plan, a product, that can then be used in the lives of individuals primarily to protect their own interests. An alternative way of viewing emergency planning is to understand safety and preparedness as acquired capabilities, effective functionings of both communities and individuals. Preparedness is not a commodity to be purchased. Instead, it's a form of public work and participatory practice. In this practice, not only are plans drawn, social media and telephone trees activated, sandbags filled, people in peril rescued. In addition, widespread grassroots discussion takes place well in advance of both the final plans and the next disaster event itself. In these discussions, both information and uncertainty are shared. Options are weighed, value priorities are debated and established. Limited resources are anticipated and mitigated through contingency plans. Local contextualized knowledge is seen as relevant to the success or failure of emergency plans and is sought out through the engagement with lay and local communities, including, I might add, indigenous knowledges when the circumstances are appropriate for that aspect of the participatory, broad participatory, and inclusive planning process. Difficult value choices and priorities are not viewed through the logic of paternalism, the expert telling us what to do, but through representative voice and deliberative participation. In the civic model, emergency planning is a type of public work. It is not simply used by people who benefit from it. Instead, it is an expression of the entire community about the value of the lives and healths of its members. It is less like a contract between seller and buyer and more like a covenant, an agreement that's entered into all that establishes commitments of responsibility for each. A little aspect of this occurs to me in the conversation in the United States right now, and probably other countries as well, about the wearing of protective masks in public as a part of the general social distancing strategy for limiting the spread of COVID-19. A consumer model would say, I'm wearing the mask in order to protect myself against you and your germs, your viruses, your aerosols, your droplets. A more civic way of looking at it would be to say, I'm wearing a mask not primarily to protect myself, although that might be part of it, but I'm actually wearing a mask primarily to protect others from my unknown infectiousness, pre-symptomatic, etc. And I'm also wearing it, perhaps now, as an icon or a symbol in our political culture. Alas, the American political culture is fragmenting ideologically once again so quickly. I'm wearing it as a statement of my civic concern for others, for my fellow members of the civic association that we belong to. To flaunt the individualism, the every man for himself, the I'm in this alone and I'll do what I want kind of attitude seems to me to be part and parcel of the underlying and never really made explicit sort of consumer model of what we're doing when we do environmental planning, what we do strategic planning, comprehensive community plans, public health emergency plans. All of which are done in communities and states all across the United States and in many other countries in the world. All of which were done when I served as an elected village trustee in a small town, when we had this kind of participatory civic planning process going on for the entire approximately 12 years that I was actively involved in it. There wasn't much difference between emergency planning vis-a-vis Hurricane Sandy and the planning that went into making our carbon footprint lower, making our green space more diverse and healthier, making our community a greener community in which to live for the benefit of the region and ultimately really the whole world as we came to understand it. So if emergency planning is viewed as a civic practice, then citizens are parties to the plan, not consumers of it. And on this view, it's entirely appropriate to emphasize broad inclusive participation and community engagement in the planning process. Emergency preparedness is one important aspect of the life of strong democratic communities. Katie, how am I doing on time? I see that we're getting pretty late.
1 minute.
Yeah, so I'll wrap it up now. I just wanted to finish with this slide that sort of sums up the understanding that I'm advocating of a way of seeing emergency or disaster planning, both in the human health realm and in the environmental realm. It's not about just supplies and equipment. It's about an entire community And the single best thing you can do to protect yourself in the event of a disaster and an emergency of public health is to have already a robust and universal infrastructure for everyday health. The better the normal works, the easier it will be for you to weather the difficulties of an emergency. That is true over and over again. And so we need to pay attention in the United States to our sadly neglected public health infrastructure and our extremely discriminatory and exclusionary acute healthcare and healthcare financing and delivery systems. And I don't even have time to say anything about our long-term care system in an aging society. We need to have an infrastructure of a community discourse, of a place where people can come together and share their common sense and their personal experiences more effectively, and not have it simply filtered and structured, pre-structured by the various social media and other technologies that are used so effectively to pre-structure the debate and to exacerbate the conflict. And then finally, I'll end on a final note. We have to figure out how to reinstate and rebuild and revivify solidarity, interrelationality, reciprocity, and above all, mutuality, care, and trust. Those, I think, are the aspects of our own hearts and minds and the aspects of our public governance in social institutions, economic institutions. Those practices that are undermining those things right now need to be the focus of change. And if we can come out of something like one of the worst global pandemics we've had in a century, if we can come out of COVID-19 by having a better appreciation of the importance of building, not bridges and walls, but building those kinds of reciprocities and trusts, then we will really have turned this horrible event, I think, ultimately to good account. Thanks very much.
Thank you so much, Bruce. And that was a perfect final note as well. And it's exactly why we're here today, is solidarity and the principle of solidarity. I know sometimes it's not easy to have these cross-disciplinary conversations where, you know, me as a lawyer jump into the data world of any epidemiologist or public health expert, but it's necessary because we need to look at what are our underlying goals that are common, such as community protection, but also what are the threats that we face. And a lot of times those are common as well, such as with political and governance institutions, denial, disinformation campaigns, dark money. So this is the purpose for these necessary cross-disciplinary conversations. And I thank everyone on the panel today. So we have time, we have 6 more minutes. So what I'd like to do is just go through a couple of the questions that were submitted. And I would still like to end at 5:30 to keep true to our 90-minute recording. And if anyone has any questions that were not answered or have further questions, please do not hesitate to email me. My email is on the ELGA webinar page where this link was. So first question. Okay, this one is to Wael. In the Anthropocene pie chart, climate change is one issue. Why not talk about all factors equally, especially in Africa? We have a little carbon footprint, but we're equally suffering the other effects.
Yes, of course. And you know, the reason I put this as a pie chart, because a lot of people forget about all these things and just focus on the climate aspect. And, you know, I'm not the best person qualified to talk about all of these, and the time limit also is not allowing us. But I do believe we are slowly moving into this area where we're taking these as a whole. All the Anthropocene, there are now areas that are being developed within the health system that are related or addressing to the Anthropocene and these. But each of these, as you could imagine, is a big issue: ecology, population, energy, you know, poverty. Each one of them is a big, complex issue on its own. The aspect of trying and addressing them together is going to be a must. And I think there are very few people who are prepared to address them all, but I do believe there are enough people to work together to address them. I mean, one of the purpose of our book that I mentioned is exactly that, not specifically addressing the Anthropocene, but it's addressing a lot of aspects: extinction, energy, biological ecology, water, agriculture, health, social aspects, governance. You know, all these things are needed as a solution for climate change as well as the Anthropocene. So I hope that kind of answers that. And yes, the footprint, carbon footprint, is much lower in many of the less developed countries, and they have the highest impact or are affected the most. Again, going back to why we put the book as free online is also that, is that we want people to get educated. Those who are in low-income countries who have no clue or feel helpless, we wanted them to kind of be able to at least do something, even if it's a little thing. So I hope that answers the question.
Thank you so much, Wael. This is a question to the entire panel. Is anyone concerned with medical waste and its sustainable disposals? And do you have any reference to any scholars or work in the area?
Yeah, I'm not. I've come across some work on that, but I wouldn't know enough to say. But I can say that it is not a major area in relation to public health, because that's a problem. Medical waste.
There is a person who works in ethics who has focused on something akin to this. Andrew Jameton is his name, and he has called attention to things like the worker, sort of occupational health and safety conditions in hospitals, in doctors' offices, and so forth in the United States. Are among the worst places to be, and the disposal of medical waste, how it should be done, what is the responsibility of the healthcare system when they hire some kind of carting company to dispose of this for them, and then it ends up floating in the Hudson River or something like that. These kinds of legal and detailed technical issues are. I mean, I have seen something on them, some reference. It's certainly not a huge, emphasis in the bioethics or the environmental ethics literature as such. But I think that, again, I only really know anything about American healthcare systems, and so many of them are for profit and privatized, that the need to regulate them carefully, because you can't really assume that they're going to follow best practices always, or have exercised the care that they should be exercising, is a constant problem. I think it's been sort of filed, but underneath environmental or occupational health and safety issues, and the agencies responsible for that in the United States and so forth. Perhaps that kind of makes it below the radar for generally speaking.
I have seen, I'm not sure if this addresses the question, I have seen some universities, their medical institutions themselves, try to go green or have a zero carbon footprint. And so I'm sure that the waste would be a consideration within that overall equation. I know Penn State, their medical school did that, because Robin was working on it, one of our colleagues. Ying, did you have anything to add with that?
Just following on your point, there's a global report on the carbon contribution from health system itself. I think there's lots of data there to estimate, demonstrate how much carbon contribution that health system itself has made so far. And in Australia, health system contributed 7% of the emission.
Great, thank you. And Ying, I think we'll just have the time for one more question, and it's to you, and then we'll wrap up. Unfortunately, I have a couple other questions, but I'll try to do it via email. In your video, it addressed individuals, industries, and government. However, transnational industries are sometimes more influential, richer than some governments. How do we manage that?
Agree that the decision-making process is influenced by multiple factors, and basically we need different engage and communication strategies with different parties. And the bottom line, I guess, is to achieve the ethical goals that Bruce has just highlighted. And if political environment permits, I would suggest voting for a more accountable and a powerful government that values sustainability above economic development.
Excellent, an excellent way to conclude. And I think I'll use a line even from Bruce's talk about public health, human health, ecological health are now merged. We need to act on that fundamental scientific understanding. So thank you all for joining us. This recording will be available on ELGA's website as well as on our partner organizations. And it was a wonderful talk. Thank you very much to each of our panelists. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Bye.